Thanks very much. And again, I'm Linda Elam from ASPE at HHS, and my assignment was to bring the federal perspective. I'm often known to go out of my lane a little bit, but I got permission this time from Paula. So I'm also going to weave in some of my experience as having been a researcher through training. I worked for the Kaiser Family Foundation for about 10 years. I then went to district government, where I was policy director for Medicaid for about 2.5 years and Medicaid director for about 2.5 years. And now I'm at ASPE, and again, I'm over disability, aging, and long-term care policy. And I like to say the silent B in there is also behavioral health, which is in my office as well. Maybe everyone's not fully familiar with ASPE, so I'll give you just a quick overview of who we are. We're an office in the office of the Secretary. The Secretary is our main customer, so to speak. We do our work on behalf of the Secretary, because we're not running a program, to have that sort of, I almost said God's eye. I did say God's eye view of what's going on in the department without kind of the imperatives of running a program. So we have an advisory role around health and disability, human services, economic policy. We coordinate the department's evaluation work, research and demonstration activities, legislative planning, strategic planning, those sorts of activities. And then, of course, we conduct and also contract out for research and evaluation activities, things like policy analysis, obviously cost benefits of policy alternatives that are under consideration either in the department or Congress. So because of our cross-cutting role, we can see overlaps and gaps, which allow us a chance to highlight opportunities to either streamline work, coordinate work, look for or figure out our own research agenda as well. You know, where we are identifying areas that we can add value, we do that as well. So in terms of setting priorities, and it's for our office, but it's really as big as HHS. I mean, when you have an enterprise as large as HHS with its vast reach, setting priorities can clearly be a challenge. And really, that happens as a balance of need, identified needs, and impact, you know, an estimation of the impact that our efforts can make in that space. Now, of course, you know, it sounds simpler than it is, because need can look lots of different ways. You have immediate health needs like, you know, infectious disease type of imperatives, but you also have political imperatives. Those are needs as well. If the administration has a particular point that they want to advance, or there's a lot of interest from the Hill on something, then that becomes a need as well. Having identified the need, though, it's what do we have, or what can we develop where we can make an impact, where we can actually move things forward. And just to give you an example of how that tension can work, my office has responsibility for updating and maintaining the national plan to address Alzheimer's and related diseases, and we also facilitate the advisory council, the Federal Advisory Council on Alzheimer's. So one of the surprises of this job was how much I was going to learn about Alzheimer's and related dementias, and it's actually been very educational, and it's a very significant public health issue with a lot of challenges and a very vigorous and vocal, and appropriately so, group of folks involved. Well, there's a lot of concern that Alzheimer's isn't, even with the support it gets, is not receiving the appropriate support. And when something comes up like Ebola, and there's a vigorous response mounted, the conversation becomes, wait, someone with Ebola in Sierra Leone is more important than I am sitting right here with Alzheimer's disease, which is a disease that is the 6th leading cause of death, that doesn't just impact the people who are suffering, but the caregivers and, and so on and so forth. And having those kinds of conversations can be very challenging, but in order to not be so diffuse in what it is you're doing, you have to be focused. And so a more domestic comparison would be HIV, which is another one that comes up a lot. When HIV became a national problem, so much was put toward finding a cure and addressing that, developing drugs. We need the same response that there was in HIV. Again, two important public health issues, but with some fundamental differences, particularly around the etiology, where you're looking for a drug to address a pathogen versus a more complex set of diseases, quite frankly, with multiple etiologies and a different sort of course. So having those kinds of conversations can be tough, but that's part of the exercise that happens around balancing need and impact. So of course, another part of the federal perspective is the large public programs that we have, which have, of course, a tremendous influence on the health of the nation, and which also serve as sort of vast repositories of data and how to leverage those effectively. The Secretary has announced, initiatives around delivery system reform, value-based purchasing, using the power of those of big programs like Medicare, and looking at paying for quality, changing the incentives to be a driver for the rest of the nation. Of course, there's a lot of research involved in that. What incentives work? How do you mitigate against unintended consequences of delivery system reform? Studying the outcomes on vulnerable populations in particular. Looking at how you coordinate programs to serve vulnerable populations like the dually eligible. And so we do a lot of that work as well. And then looking at how to best utilize disparate programs, so not just HHS programs, but across government, and I would say even extending out into private sector as well, public-private partnerships. Lots of opportunity there, but lots of challenge as well. And the housing example I thought was a tremendous example. Our office does quite a bit of work looking at supportive housing for people with the chronically mentally ill, and also for seniors. And there's so much promise there. And I think probably everyone in this room is like, I get it, housing works, housing is healthcare, But then you start getting down to the nitty-gritty of how are we financing this? And if we're talking about offsets, how are we justifying those offsets? And how are you building the argument to look again at how we weave these programs together for people's health? Obviously we spent, and another thing I want to point out is the reentry population is another area where we have a lot of conversations now with justice, with labor, with HHS about how do we look at the aftermath of mass incarceration, and how do we help people reintegrate into the community and stay there. And of course, given the health needs of the population, getting them health care is primary, but there are also significant needs around, of course, jobs and everything else it takes to live in the community successfully. The Affordable Care Act, obviously there are a lot of opportunities, as Ron said, looking at how effective that has been, monitoring how well it's rolling out, demonstrating its effectiveness, strengthening it, quite frankly, kind of putting markers in to preserve this work, and then also helping people make decisions. So the facilitators and the navigators and assisters are very important, but also helping people deal with volumes of information and types of information they may not may not have had before, helping them make choices, sort of like the nudge model, where you're not directing them necessarily, but helping them stay within zones that, where they can make effective decisions. And that kind of ongoing work, what nudges are effective, and helping people make the choices where they can best be served, a very critical area that a lot of people are talking about right now. So we're going to learn a lot about insurance coverage, but now shifting into my former life, we will also learn about the limits of insurance coverage, because for a lot of people, that has been like the golden ticket, get people covered and they will be better off. Well, absolutely, coverage is important. I've got 2 minutes and I will be really quick, pithy. Coming from the district where we had tremendous coverage, in some ways we were the #1, like child health coverage, we were #1 in the country, underappreciated fact. Didn't have urban-rural issues, did not have a paucity of providers. The district has a nice concentration of providers, not evenly distributed. But if we were going to do a different kind of mapping, if you look at the metro map for the metro in the District of Columbia, and you look at health outcomes along the metro, you see a tale of at least 2 cities, a lot of which is masked. Overall the district looks pretty good, but as Medicaid director, the population that I worked with wasn't doing so well in a lot of ways, and they had coverage. So again, how do we get coverage to work for people, and how do we get other parts of what will impact people's health woven into how we address and deal with their realities? Not so that they have to do each and every piece of their work to try to survive or maintain in the community, take care of their children, but that as the providers, as the folks who pay for it, we can set up structures that allow people to get what they need more efficiently and in ways that serve them. I just want to give a shout out to my sister in state service, wherever she is, who talked about letters of support. That happened to me many times. The idea that at the 11th hour, a researcher would drop in with a fabulous idea, and the grant, like, we're out of time, so just please sign this and we'll work it out, is not a model for partnership. And it wasn't because I had a health services research background that made me worthy of that kind of respect. It's that I was running a program where I knew what our needs were. I knew the limitations of our data. So sometimes I wasn't just being obstinate. It was, I can't give you what you want because we don't collect it in that way. And if you had talked to me earlier, we could have come up with something that would have worked for both of us. And so the last thing I'll say is that, and I love truth and beauty as much as anyone. I love a perfect answer. I love all of that stuff. But I would submit to you that if this is your calling, if population health is where you really feel, that you're doing, your work, that at least on some level, and not everyone's going to get messy and down in it like I did, but at least on some level, you have to pay attention to that inelegance and look at the real world and how your work can be best leveraged by attending to those realities sort of in the planning to best move along your efforts and best serve the population as well.